Okay, you ladies, it is so nice to see you. My name is Lisa Breckenridge, and I have worked in television my entire life as a journalist. Really, one of my main focuses, though, especially as I've gotten older, has been focusing on women and how we age, and that's really what I talk a lot about on my website and on my Instagram. So I think that's why they have me here. And I know some of these doctors, and they are amazing. I just can't wait for you to meet them. So we're going to start with Dr. Suzanne Gilberg Lenz. Why don't you come on up? Um, yeah, I think you just have to hike up. Come on. There you go. Next, we have Dr. Nicole Weinberg. Come on up. And then, you need help, honey? Are there steps? We just missed the steps completely. And Dr. Rhonda Voskuhl, please come on up. And there are steps. I'm going to start with Dr. Suzanne. I know you the most. You kind of started with me on my menopause journey
Yes.
of sharing information about menopause
Yes.
with people back when I don't think a ton of people were talking about it. And when my friends said, "What are you doing?" "I'm having a lunch. We're talking about menopause." I think most people thought I was crazy. That was like 5 years ago.
Yeah.
And you've seen a lot change, but go ahead and give us a little bit more about your background. You're an author, OBGYN, amazing expert.
I mean, I'll give the 2 second. Hi, everybody. I'm Suzanne Gilberg, also known as Suzanne Gilberg Lenz, lots of names. I'm board certified in obstetrics and gynecology. I focus only on gynecology at this point. I've been in practice for 25 years. Born and raised and trained here in Southern California. I'm also board certified in integrative and holistic medicine. My specific training is in Ayurveda, the ancient indigenous healing system of India. And I got really interested in menopause for a couple of reasons. I started seeing a lot of young breast cancer survivors early in my career and really realized the deficit in my training and knowledge and started pursuing more deeply that time of life because my training is in full spectrum women's health, adolescence through the end of life. And I realized I just didn't understand it enough. And then when I would do a lot of these public speaking things, at the end of any talk I gave, people would ask me, what are bioidentical hormones? Everybody wanted to talk about menopause. So I really got deeply into it. I created something called Menopause Boot Camp. Someone just came up to me who trained in my certification program, which is really beautiful. And I started doing these events in Los Angeles because people didn't know what the hell was going on. And I couldn't teach them in 7-minute encounter with your pap smear. So I created an experience that grew into a book that was published by HarperCollins in 2022, and everything exploded around that time. And I know you're going to ask the question, why do you think that happened? And I will let you ask it, or no, I can answer it, whatever. But that's who I am.
Yeah.
And it's just really satisfying to see a room full of people who I think know a lot more about this than maybe you think you do. And then certainly when Lisa and I started talking publicly about it 5 years ago.
It's crazy. It's crazy. We'll go ahead and let everyone introduce, and then we'll jump into all of that. Dr. Nicole Weinberg, you specialize in the heart, correct?
Yes, absolutely. I'm a cardiologist. I'm a non-invasive cardiologist, so I don't do procedures. I won't put a stent in you, or you won't end up with a pacemaker if you came to see me. But I do a lot of prevention. I do a lot of women's health. I read ultrasounds and stress tests and just try to keep people going. Heart disease is a leading cause of death, so a lot of people come my way with a variety of different symptoms and things that are going on in their universe. And I feel that we hear our bodies in ways that, our male counterparts don't always. And so I feel it's wonderful. It's a wonderful journey because patients end up coming to me first. Sometimes they say, my heart is going crazy, or my blood pressure's up, or I'm gaining weight and now my cholesterol is abnormal. What is going on with my body? And so there's a lot that we can learn just from focusing on the heart first.
And next we have Dr. Rhonda Voskuhl, and you specialize a lot with the brain.
Yeah, so I'm a professor of neurology at UCLA and the director of the MS program and the faculty neurologist for the comprehensive menopause program at UCLA. I actually have the Jackie H. Skirball chair, so we want to thank Skirball for hosting this, a lovely place. They've helped many avenues of doctors we don't even know about. So I basically started from the aspect of multiple sclerosis affects women, and estrogen is so good, pregnancy is so good for them. A loss of estrogen during menopause is bad for them. Their disabilities get worse. And then I began to branch over and figure out why is that. Found the cell in the brain that could be targeted by estrogen. How could this be harnessed for menopausal women that have brain fog? And so what we did is I'll end by saying I created I have patents in the United States and Europe, and based on our publications at UCLA. And we basically have a treatment for menopause-related cognitive decline, and it's called Pearl Pack by Cleopatra RX. It's nationwide as well as the UCLA Menopause Care Program, but it's something that's direly needed. Our brains are, I think, who we are, and to lose memory and some of the things we need to do. We finally reached a time in our lives where we have some flexibility, some power, such a central part of our families and our jobs, and we have to have our brains. So.
Who has brain fog in here? I'm just wondering because I don't know about you, so that's amazing. Okay, so let's start with some of the questions we have, and then we'll have time for you guys to ask some questions as well. As we kind of alluded to, menopause feels like it's such a hot topic right now. I think every other celebrity has some type of endorsement if you're Halle Berry or you're Naomi Watts or even Brooke Shields. Why is it such a hot topic now? Why did it take so long? And is it because people figured out they can start making money off of it? I mean, where is the truth in all of that?
Well, I actually don't think it's because of making money off of it. I think the treatments are actually not expensive. They're cheap, and that's why they haven't been developed. I think the reason they are being developed is because women are finally in a position of power, like speakers or publishers or Oprah or Maria Shriver, and they are saying, hey, we've had it, we want to do something for other women. So I actually think it's an altruistic thing is why it's happening.
Yeah, I tend to agree. I mean, I think it's a distinctly Gen X thing. I think that our generation has a very specific way of looking at our experiences and our expectations. We're highly independent. I mean, there's a lot of joking around about how we were raised in a feral manner, which means that we're very resilient and we have opinions and we are not afraid to share them. But I also think there were some cultural forces that came to bear, Lisa. I think that on the heels of Me Too, and then the lockdown, everybody went online. And I think my generation in particular, I was always involved because I'm a public speaker, but I think that women who weren't online as much suddenly went online and started seeking information and community. And to me, that was the perfect storm. And everybody started talking about it. And I think I agree with you, Rhonda, but look, a lot of who's hopped on this is the beauty industry, and this is a multi-billion-dollar market. And women over the age of 45 control a massive amount of capital. And so there are capitalistic forces at play, which we live in the United States. I'm not mad at it. I think it's our opportunity to seize the platforms and to talk about this and to get care, because the problem is that we were shut out of the conversation.
Well, isn't it true that you guys barely had, how many days or hours were spent on menopause when you were going through medical school?
Not enough, not enough. Older women are not valued in this culture. That's part of it. Also, my dad is 88 years old and still a practicing physician. And I will never forget in medical school calling him and saying oh my God, Dad, pharmacology, it's going to kill me. I can't do this. And he said, I said, how did you do it? And he said, what are you talking about? There were like 5 drugs when I went to medical school. Okay, so let me just point out that medical training has not changed in terms of the amount of time in all this time, and science has evolved. So we do not get enough training for a bunch of reasons, and I'm an obstetrician gynecologist. I got almost no training in this. But I want to say 2 things about that. One, I got more training than people younger than me because it was pre-Women's Health Initiative, and I didn't get no training. It wasn't focused on a lot. I was also learning how to do surgery, take care of pregnancy, well woman care, cancer. So there's a lot to squeeze in, and it's called the practice of medicine for a reason, because you are continually learning. Number 2, I really want to be careful about piling on doctors who are already traumatized and are experiencing massive amounts of moral injury. You guys are familiar with that term? If not, look it up. We are not, I'm sorry, we're not the problem. Doctors are not the problem. The system is the problem. We're on the same side as you. We are your allies and your friends. We need to join together. So it's true that we don't get enough time, but there are other ways to make things happen, and I think we're starting to see that happen, which is beautiful.
100%. For you?
What I was going to say was, if there's one good thing that's come out of COVID, which is there's very little, and I mean that a little tongue in cheek, but there's a lot of AI technology that people are able to get at home. And so one of the things that I really like in my field, and I feel it translates into a lot of different fields of medicine, is the ability to gather data on yourself at home. And some of it is mush data, but some of it is actually very good and has spearheaded a lot of different research moving forward. So I think, our patients are really driving the car now. They're telling us, how they're feeling and what's going on. And I feel that it's a little different than, well, let me tell you what your problem is. It's a little bit more of, let me tell you what is bothering me, and this is the interesting data that I have gleaned on myself at home. Can you fix me? And I think that's very, very interesting.
So the whole topic of menopause, in case someone here doesn't understand or know, or I had my son's 18-year-old girlfriend ask me yesterday, when does menopause start and exactly what is it? And this is at dinner last night. So I was like, okay. I mean, I never would have asked that. So who wants to take that on? Just define menopause, when and how
I'll
do you
do
know?
that one. I'm sure my colleagues understand, but this is what I talk about all day, every day. First of all, that's amazing that your 18-year-old, that's so cool, and that's exactly what we want, because part of the education gap is just girls and women not knowing what their bodies are going to go through. And I have watched during the course of my career pretty much every stage of our body experience get destigmatized, which is beautiful. So now we're just kind of moving through, right? Pregnancy, periods, sexual health, breastfeeding, whatever it is, fertility. So now we're just moving through it. So the definition is really quite simple and quite clear. It is 12 consecutive months without a menstrual bleed between the ages of 45 and 55 for no other medical reason. Chemotherapy, a hysterectomy, an ablation, maybe you have an undiagnosed thyroid disorder, something else. So very, very clear, 12 consecutive months, no bleed, you have a uterus, you're 45 to 55, there's no other reason. Perimenopause is super fuzzy and confusing, and I feel like people use the term menopause and perimenopause interchangeably, and I don't care. It's okay. They're words. It's about the experience. Perimenopause is the 7 to 10 years leading up to that final menstrual period. Menopause is a day. It's a day of your life. Postmenopause is the rest of your life, a third to a half of that. So hopefully that helps level set, because it's hard to speak if we're not speaking the same language.
We're going to talk now about hormones, which have been so misunderstood for a lot of reasons, dating back to the early 2000s. And so I think a lot is now being understood about them, being more widely accepted. And I want to start with you, Dr. Rhonda. The effects of hormones on our overall cognitive health and brain health.
Well, estrogens are normal. They keep us young. They're physiologic. And loss of estrogen is very bad for multiple organ systems. It's bad for the skin. It's bad for the bone. It's bad for the genitourinary length, vaginal dryness, urinary incontinence. It's bad for the brain. Now, in what way is it bad? So it's not decreased IQ. We're just as smart as we ever were. What it is cognitive domain-specific problems. What do I mean by that? It's particular things. Verbal memory. Can't think of the word. Can't maintain train of thought if get interrupted. There are other things. Reading a book, and you get it, fine, but then it doesn't stick. So these are problems. Now some people don't think it is a problem. It actually is a problem, because when you're trying to be in a meeting, or you're trying to give a speech like this, or a variety of other circumstances where you're in a conversation at dinner, when you lose your train of thought, it's embarrassing, it undermines confidence, it undermines your authority. So this actually is a problem. Is it IQ? No, it's not. We can do lots of things just like we always could, but this is a problem. The other thing it's not just, oh, well, they've been told, oh, well, they just can't sleep. Oh, they just have hot flashes and they can't sleep. I agree, sleep is good, there's no question, but they're not mutually exclusive, and that's not all of it. The reason I say that is because hot flashes get better after 3 to 5 years. They're gonna get better on their own, but this cognitive problem does not. Indeed, the opposite is the case. So women who have been menopausal for 13 or more years compared to those for a shorter period of time, it's been shown that on MRIs of their brain, there are areas of the brain called the hippocampus and frontal cortex. It's just a detail, but these areas, they undergo atrophy, and they have problems with functional connectivity between each other. Now, so what I'm saying is it's affecting brain structure function. So it's not just that they can't sleep a few nights. This is actually serious, and it needs to be taken very seriously. It's not whole brain atrophy, it's not IQ, but it's cognitive domain-specific problems, and it's regional problems with the brain.
Also, you do a lot with looking at dementia and, as you mentioned, MS with estrogen.
Right. So let's talk about what we can do about it. So I started with the MS field because most MS people are women, and it's well known that during pregnancy, MS is very good. Estrogen is very high. Estradiol, estriol, there's a unique estrogen called estriol. It's made by the fetal placental unit. These MS women do very well. Less inflammation, and actually it delays disability accumulation later. Postpartum, the hormones drop precipitously. It's bad. So there you go. And the last element, again, is in menopause. MS women have disability worsening during menopause. Estrogen's up, it's good. Estrogen's bad, estrogen's down, things are bad. So I'm just kind of a common sense sort of person. I think there must be something about these estrogens, right? So I started to focus on the estrogen as being a neuroprotective. Then if you look at, again, another example, just aging. Otherwise, healthy women, not MS, healthy women, they have brain fog, and it's what I just described. Again, estrogen's down, we have another neurodegenerative condition, really, that's aging. A lot of things we can't do about aging, but some things we can, and that's not let us have unfettered loss of estrogen and do nothing about it. Now, I'll get to how it's complicated, that treatment. The last thing is we worry about Alzheimer's disease. Many of us have seen it. It's very prevalent, and it's very bad. And the entire world kind of knows that it's too late once people have Alzheimer's disease. The treatments are very hard to reverse something. All the big pharma, all the NIH work is now going on in mild cognitive impairment. It's the 10 years prior to Alzheimer's disease, right? Well, you know, Alzheimer's is 2/3 to 3/4 women. So what does it look like when you go from Alzheimer's disease 10 years earlier as mild cognitive impairment? What's 10 years before that? It's women with cognitive issues. And it's in these same brain areas that are also occurring in Alzheimer's disease. Now, they have a whole brain by the end. Now, do we know that those cognitive issues of menopause cause Alzheimer's disease? The answer is we don't. And this is my hypothesis, though. I think it's there's a logic tree here about it's mostly women, this predates that, and that could predate that. Will we know? We won't know the answer until we have a treatment, an intervention to reverse. And we have no treatment. I can talk to you about one of them we're doing that's got a patent, but the idea is you've got to have a treatment, and you've got to treat enough of these women with cognitive brain fog of menopause, otherwise healthy, and after 10 years, maybe we'll find out, and 1,000 or more people, maybe we will find out that will reduce the frequency and severity of mild cognitive impairment, which will reduce the frequency and severity of Alzheimer's. That is my hypothesis. That is not proven, but I don't think we should let these things go untreated, unfettered, these cognitive issues of brain fog.
Amen to that, right? Amen. Dr. Suzanne, I want to talk more about the body and hormones and how they can help and what we need to know about the effects of our functions.
Well, I mean, thank you for saying that. I'm like so excited to meet you. Well, that's the thing. So, I mean, Rhonda kind of set it up. The reality is that, first of all, I think we always focus on estrogens and estrogens. They're not one thing. We're not here for a medical lecture. It's a short talk. But there's more than one. But we also, basically what happens is we have rapid, unpredictable fluctuations in our hormone levels, and that is estrogens and progesterone over a long period of time, and then sort of a slower decline of testosterone. So it's not just like everything goes into the toilet immediately. It's during that perimenopause where the unpredictable hormones are at play that I think we start seeing a lot of the development of problems. And Rhonda's right, and I know Nicole would agree. We just do not have enough understanding of what is exactly happening, but we have common sense and we have other scientific inquiry that would support ideas. Okay, I don't want to get too in the weeds here. We have estrogen receptors, if we just look at the dominant hormone, in pretty much every tissue in our body. Okay, that is the vascular endothelium, that's the lining of your blood vessels, that's your brain, that's your bones, that's your joints, that's your heart, it's your GI tract, it's everything. It's not just the quote reproductive tract, it's not just the vagina, the bladder, the uterus, the tubes, and the ovaries. So you are going to have a full body experience if those hormone levels that are locking into that, lock and key, the lock is the receptor, the key is the hormone. I just told you the hormones are going all over and the locks are everywhere. So if you have a period of time where you have a very predictable experience, then it goes into unpredictability, and then it goes into precipitous decline. You guys can understand that the entire body is going to be involved and things are going to change. And I'm sure that tracks with anybody in this room who's had any weird ass symptoms, right? I mean, dry mouth, right? I'm not going to list them all because you know them all, and everybody's gotten a listicle on their feed. So it's a full body experience. And I think, again, to put a finer point on what my colleagues have said, I'm a breast cancer survivor, so I feel like I can say whatever I want about breast cancer, okay? I'm not, don't be afraid, don't be afraid. I'm not a big fan of fear. Your number one killer is not even, breast cancer is not even close to the number one killer. It is heart disease, dementia, and osteoporosis. Okay, so these are the things that we need to be talking about if we want to talk about longevity, prevention, and optimizing where we are now and in the future. And I'll leave it at that.
Okay. And we have about 10 minutes left, and I want to get some of your questions. We could talk for like 2 hours, as you know, all day. But Dr. Weinberg, we're going to go to you about some of the recent findings with hormones and heart health specifically.
Yeah, so as we've been talking about, hormones affect every organ system, but because heart disease is the leading cause of death, it's one of the things that we get to focus on a lot, because being able to identify your risk factors for disease and potentially modify them could save your life. And knowing about them as early as reasonably possible is how you combat that disorder moving forward. So with hormones, when you have high levels of estrogen in your system, you have generally better cholesterol, generally lower blood pressure, generally better blood sugar issues. And so as the hormones start to decline in your system, those are the things that change. And those are our main risk factors for cardiovascular disease. So your LDL, which is your low density lipoprotein, that's the bad cholesterol that starts to elevate. Your blood pressures can start to elevate. Your weight can change, your blood sugars can change. And so when you put all of that together, it's like a perfect storm. And so you start to go into your risks of cardiovascular disease, and we become equivalent as our male counterparts about 10 years after menopause. So if there are men in your family that have cardiovascular disease at age 50, you're going to be on that path around the time of menopause, and it would be great to identify those patients and be able to treat them as early as possible. Some of the issues that in the world of cardiovascular health, and this is brain and heart, came with the different dosages of hormones that were given to women over the years. And there were big studies that we're all aware of in the early 2000s that had higher hormone levels, and it was oral medications, and they were being processed by the liver. And as your liver breaks those things down, you end up having increased risk of blood clots. And so there were lots of strokes, there were lots of blood clots, there were lots of heart attacks in some of those patients as we were kind of understanding how to combat hormone loss in our system and how to replete it. The universe is much better as it relates to that now. We have a lot of different titrations of therapies, different modalities of getting hormones into your system. And so there are a lot of women now that are on good doses of hormones to combat some of their symptoms. And we've seen some of the changes come into their risk factors for cardiovascular disease and stave some things off, but it by no means means that you wouldn't be paying attention to these risk factors moving forward. It's just part of the big picture of how to take care of yourself.
We all want to feel our best. And it was told to me one time when I first started taking my hormones, well, back in the olden days, women just, once they hit 40, they sat on the porch and rocked in the rocking chairs and they did nothing. That's not the way I know you want to live, Lisa. So this is what you need to do. And it was all the different hormones so that I could be active. I mean, I'm just going to tell you this. I was at a wedding this weekend with Diane Cannon at 88, who was dancing on the floor longer than anyone else. That woman has so much vitality in her. And I think we'd all want to live like that. Is there a one size fit all for the hormones? I mean, there's the cream, there's the pellets, there's the pills.
So as was mentioned, estrogens, they're an umbrella term. Estrogens are not all alike. And so there's estradiol, which was in most of those older studies. And it is taken as a patch because there's a first pass dose effect. It's converted to estrone that causes clots. Now, I am concerned about estradiol and some of the concerns about breast cancer because it binds the estrogen receptor in the breast, estrogen receptor alpha in the breast. And so when I tried to find a treatment for the brain, I actually used the pregnancy estrogen. It's called estriol. It's not estradiol. They're not all alike. They bind estrogen receptor alpha and beta differently. And so I loved estrogen receptor estriol because it binds to beta. Beta is in the brain, and we showed how it can be neuroprotective, what cell it was acting on, how it worked. And the beauty of it is it binds weakly to alpha in the breast. So you've got something that it's maximizing efficacy based on one receptor in the brain and avoiding some of the deleterious effects of the receptor in the breast. That's the whole concept. It also is not converted to estrone through a first pass liver effect. So the answer to your question is this has been the problem. They've thrown the baby out with the bathwater when they give estradiol, and they give it by these different ways. You need to find a better estrogen that binds to one receptor, not the other, doesn't have the first pass dose effects, and that you can develop a next generation estrogen. And this estriol that we're using actually, by the way, has been used in Europe for 40 years for hot flashes and been shown to be safe. And so the reason it won't be developed in the United States, maybe ever, because it's inexpensive. And that is my anti-capitalist. I'm just saying, when things are not expensive, they don't get developed. And then we've got, patents, we've got NIH grants and publications. But if it's not got a big price tag on it, guess what? So bottom line is, yes, the type of estrogen matters. The dose of estrogen matters. We showed the estrogen levels correlate with improvement in cognition, the estriol levels in the blood. Type matters, dose matters, timing matters, it all matters. It's not easy. That's why there has not been a treatment to correct brain fog until hopefully now with what we're doing with Cleopatra RX.
And I want to be really clear because this can be very confusing to people. And I just want to emphasize what you started the question with. It is not one size fits all. It is very important that you engage with a physician who has legitimate credentials and training in this. It's very nuanced. Your needs and the science will continue to evolve. I actually feel like I need to shout out to estradiol because there's a lot of data on safety and on efficacy and on longevity and on really well designed studies looking at estradiol safety for treatment for symptoms. I always tell people we got two buckets. We've got symptoms and we've got long-term health issues. And we do have data on both of those. So I do feel like I need to disagree with you on that. I also feel like I need to level set about the Women's Health Initiative and oral estrogen. The Women's Health Initiative was not looking at this room. It was looking at women who were at least 10 years past their menopause. The average age was in their 60s. Many of those women had already been on hormones previously. Many of those women had active cardiac disease and risk factors prior. So I think when we quote that data, we have to be very careful because we are insiders and they are not. So I want to be respectfully disagreeing or maybe just clarifying, and I don't want to dominate, but I really don't want people to leave this talk and be like, oh my God, I'm on the wrong hormones. I need to be on this. I should have been on that. I'm doing la, la, la. And then the last thing I'll say is that the one lesson from the Women's Health Initiative 20 years later is that actually most of us are amazing candidates for hormone therapy. It is not true that most of us should not be on hormone therapy. The choice is yours in the context of legitimate education and shared decision making. I don't think everybody here needs to be on hormones. I think they need to be offered safe options. And the foundation of health is lifestyle. I can dip you in hormones all day long. And if you don't take care of your stress, your movement, your sleep, your socializing, your spirituality, your sexuality, you're not going to do better or live a healthier life, in my opinion. So it's always all of those things. It's all of the things we're talking about together.
Yep. Do you want to say real quickly?
I just wanted to say one thing. So the old studies, the old HRT studies that were so long ago, you know what? I told you that the brain problem is cognitive domain specific. They looked at, it wasn't designed or tailored to even look at brain. Years later, they said, oh, how many people were demented? I mean, my goodness, is it Alzheimer's? Is it cardiovascular? They didn't do cognitive domain specific. And then if MRIs were done at all, they would say, is it whole brain atrophy? No, it's like, so the point is they were not even designed in any way, shape, or form to look for the effect on brain, which is what I do, clinical trial designs for brain, and they were not even looking at that, so.
Okay. Go ahead.
And the last thing that I'll say about that is, to your point, when our bodies are changing, this is a great moment in time to say, okay, what is going on and how can I modify my lifestyle and or start hormone therapy and or be on other drug therapies to combat some of these changes, because there is a little bit of a buzz term of the timing hypothesis, which has to do with, as our bodies change, you want to kind of head things off at the pass and be able to change your trajectory of disease instead of being maybe a rapid rise because your hormones are coming out of your system and blood pressure, cholesterol, weight are changing. You want to change that trajectory of disease. So maybe it is different drug therapies or maybe it's a lifestyle intervention. But really, the perimenopause and menopause time of our lives is very, very critical.
I'm going to open it up. I think we have time for maybe one or two questions. Go ahead.
I just feel like there's so much information. We're so overwhelmed. And like, how do you go in and talk to your doctor and say, like, this is happening, I need to be on HRT? Or like, what are the questions that you feel like we need to directly ask? And I ask because like, I just had endometriosis surgery and had a hysterectomy and was offered some different stuff, but because of my personal cancer history, I can't get it. And then I try to talk to an OB and can't get a straight answer, and a surgeon who's telling me something else. So what are the like streamlined questions, excuse me, that we should be asking?
Yeah. Yeah. Let me just say, like, thank you for asking that question. I know it's really hard and it's really overwhelming. I have a couple of pages of advocacy in my book, like how to prepare yourself. First of all, do not do this at an annual visit. Your doctor doesn't have time. Make sure your doctor actually is interested and informed in this area. Call, ask the staff, ask them, is this something that I can make an appointment with you about to actually have this conversation? I have a lot of questions. Ask for what you need and move on if that person isn't your person. It is hard to tell who's doing what. There's a lot of, especially in LA, there's a lot of people who are amazing, a lot of people who I think are absolutely, I don't know what the hell they're doing. And I think in the past I've told people to go to the Menopause Society and look at their list. That's better than nothing. I don't think it's necessarily the best. Heather Hirsch Academy, anybody who's trained through Heather Hirsch, or a nurse practitioner named Jackie Piasti, they both have outstanding menopause training programs. And telehealth, there are great telehealth options out there now too. So I think it's very, and then finding amazing unicorns like these two who are specialists. But in terms of the treatment, the hormone treatments, it is complicated. Try not to be too overwhelmed and make a specific time with a specific person who this is what they do.
You have something at UCLA.
Yeah, UCLA has created the UCLA Comprehensive Menopause Program, and it was featured on the Today Show with Maria Shriver. It's December 26th. You'll hear about Cleveland Clinic's got one. So what they did, they've got 8 GYNs that are in Santa Monica and UCLA. And because this is so overwhelming and confusing with multiple organ systems, they basically have brought in an expert on bone, actually 5 or 6, on heart, on brain, on the brain person, and all the organ systems. So you don't have to figure it out anymore. You can go to your GYN as your central regulator, and they basically get all these consults to the different, we've got 9 different experts that they all can go to. So it's one system integrated.
Did you have something you wanted to add to that as well?
Oh,
No?
no.
No. Okay, one last question.
So that's what they're doing at UCLA. That's the problem. It's you've got to be your own advocate and you've got to be a doctor to figure it out. So what they did is they've got one central system with an algorithm that says to three experts you need to see, 5 you don't. And every year they see people from the age of 50, doing DEXA scans at 50, cognitive tests at 50. So they track you the whole way through. And everybody looks the same epic database. We all do. So it's really nice. It integrates it for you.
Well, I have a concierge practice, and that is exactly what I do. So I have 30 to 60 minutes with the patient. I actually was on a Zoom this morning with a patient out of the country and her physician. I understand this is not available to everybody, but one of the reasons that I left my long-term practice to do this is that everybody's falling through the cracks. They need a cornerstone physician, so I can do that. If UCLA is available to you, great. I've had mixed experiences. I've had patients leave there and come to me. I'm just being honest. I don't want to be disparaging, but I just feel like I have to be honest. And I think that is a unique scenario. And if people can access that, that is ideal. That is ideal because you can't do this alone. And again, we have to be our own best advocates.
The cholesterol conversation is very multi-tiered. Cholesterol is one risk factor of cardiovascular disease. It is not the only risk factor. It is one piece of a very large puzzle. So it's important to identify, who is at risk. You check their cholesterol. There's other blood work that one can do. There's advanced lipid markers that kind of tease through the data of who has maybe larger particles within their LDL that your body has the ability to break down. You can also look at other things like whether this person is actually depositing plaquing in their arteries or not. And perhaps if they're not depositing plaquing and their otherwise risks are very low, maybe that's somebody that you're just going to monitor over time. So it's one piece of a very large puzzle. In terms of treating it, I will say the universe of treating cholesterol, that's probably another day or a lecture later on, but once upon a time, it was one size fits all, and I'm happy to say that in the world of preventative cardiology, it's not anymore, which is wonderful. There's a lot of different methodologies out there. There's a lot of different drug therapies. There's lots of different techniques to get people's lipids low because it is something that's very weighty as it relates to not only cardiovascular health, but also brain health as well.
Okay, one or two. Okay, go ahead right there. How do they get in touch?
Yeah, so you can go to cleopatrarx.com and you can get a lot of information. A lot of my papers are posted and what we're doing. Also, of course, the UCLA Menopause program is also there. So Rhonda Voskuhl, it's Voskuhl, Rhonda, UCLA, Cleopatra, RX, whatever.
Go ahead.
So we started a charity to help with community education. So this is something that we're very passionate about. It's called Have a Heart, Save a Heart. And so you can find that on Instagram. I'm also somewhere there, but I don't check it all the time because I'm old and I have no idea how to work that stuff. But there are people that are in my universe that can help you with that. I also work at Pacific Heart Institute out of St. John's, if that's at all helpful.
I'm kind of all over social media. I think that's the best place to find me, and then you can find my practice and the rest of my information.
It's Ask.
It's at the main account is Ask Dr. Suzanne.
Yes. Because you always want to ask her. Okay, you had your hand up over here. I mean, it's definitely different. An OBGYN will say one thing to me at times, and then the longevity specialists will be
Okay.
like, oh, no, we're going to bump you up.
First of all, there is no data to support checking levels. That's not why we prescribe. We prescribe, like I said, for the two buckets, for symptom management during that difficult period of transition and for the long-term health issues that you hear us talking about. So I really appreciate where you're coming from, and you're 1,000% right that women need to be doing everything they can or at least have those opportunities offered to them. But you're getting pushback from those doctors about testing because the testing is not evidence-based. If they're getting pushback about being on hormone therapy, I would want to drill down into that more. And you are 1,000% right that doctors are pushing back, especially right now where women are coming in and advocating for themselves, and then they're getting upset. Oh, you heard it from a social media influencer, la, 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 la. And it's like, instead of dialing back and just saying, oh, okay, she doesn't feel well, what is she actually asking me? It's hard to answer the question. And it does get back to what I was talking about. Your doctors are so pressured and have no time. If your doctor takes insurance, they don't have time. And if they feel attacked, because they're human beings too, they may not be able to, maybe they haven't, done therapy or, I don't know, gotten a good night's rest. They're not their best selves. So we have to come in and say, hey, I don't feel right. And you can really counsel your patients. How can we partner together so that I can feel better and have better health? I'm not against functional medicine per se, but you don't have to go to a functional medicine doctor. You have to go to a doctor who cares, is informed, and feels like you want to partner with them. That is on us as well. It just is. It's another thing we have to do as women. But guess what? We're just going to have to do that. We can do that. And then we make it better for the next generation. And thank you for doing what you're doing, because strength training is super, super, super important.
I know we have to make time for the next panel to come up. I so appreciate getting to sit here and listen to all of you. You guys are the first line of defense. We have to be our advocates, and then to be able to have experts like you to answer our questions and share your knowledge is amazing. So again, thank you so much for being here and helping us. And follow
Thank you for
them
having
if you
us.
can on social or their websites or anything like that.